My name is Tassin Chowdhury. I'm a consultant at the Royal London Hospital. That's big blue building across the way, and it used to be part of this building actually. And I don't remember it looking anything like this. I mean, it just is a remarkable place that London Borough of Tower Hamlets have made here. It's absolutely gorgeous, and it's really a delight to be here again. And it's a delight to see so many people interested in the health of Bangladeshis in East London. Thank you so much for coming. 1 in 4 people in the hospital across the way is a person living with diabetes. Okay, so 1 in 4 beds. There's about 600 beds there. About 150 people with diabetes are in that hospital. And the reason they're there is because of complications related to diabetes. So the first bit of this day is going to be talking really about diabetes. And you're going to hear a lot of information. So the first sort of section before coffee is lots of information about this health emergency. This is an emergency that we would like to convey to you. So you're going to hear lots of information about this issue. And then we're going to have, after coffee, much more scope to have discussion. We're going to have a panel of experts to give their opinions. We're going to have you working on tables to try and come up with some solutions to this really, really big issue. In the afternoon, it's more about cancer and vaccination, but we're focusing really on diabetes this morning. I'd like to introduce Riyad Karim, who's really been the driver of this. We'd like to also just thank Aoife Slattery from Diabetes UK, who've been amazing at organisation of this programme. But Riyad is going to just give a few words on behalf of the London Bangladeshis Forum, just to give you a little bit about what the background of his work and what's going on here.
Okay. Good morning, Assalamu alaikum, and welcome to the London Bangladeshi Health Inequality Summit. I feel quite emotional just seeing you all here today. And I suppose it's my job as a co-chair for London Bangladeshi Health Partnership and my day job as Assistant Director for NHS England and the Community Engagement Vaccine Screening Equity Lead is to bring people together. Bring people, place, system, and region together. Bring public health teams, local government, NHS, and our faith and community sector together. And we're here together today to talk about this very important subject of the state of Bangladeshi health in London. So I really warmly welcome you all to this lovely area, actually, lovely part of thriving East London, and in this wonderful building and this environment that we see ourselves here today. So a warm welcome to you all. And today really is a call to action. It's a call to action, and I suppose it's about time, isn't it? Bangladeshis form 322,000 in the last census across London. Bangladeshis are the most poorest ethnic group in London, and they live in the most deprived areas as well. And I remember in COVID, when I was an assistant director in primary care, how I had to get my hands up and kind of work and get the overalls on and help the doctors and the nurses and the pharmacists in this Herculean effort that was the COVID vaccination program. And it was together that we were able to then connect with our trusted faith and community leaders and able to get the message out. And so today we're really looking at bringing place, system, and region together to see how we can advance health equity for the Bangladeshi population. And it's great to see you all here today. So the London Bangladeshi Health Summit is a call to action, a warm welcome. And I suppose that why, how and why did we form? So the key things came from COVID. And I remember the important disparities report. And it's great to see Professor Fenton here. And Kevin knows how inspired myself and so many others were activated in that national emergency of the COVID pandemic. What can we do? What could we all do for our country, for our community, for our nation, and for our family? What could we do to save lives? And the key thing, what we learned from there, was the importance of community health inequalities, the importance of building trust and confidence with the communities, the importance of bringing people and place together, working with trusted faith and community leaders, utilizing their trusted voices and channels, and utilizing the trusted places of worship, like, say, for example, just down the road, East London Mosque. So many women's groups, so many places were brought up, even in Enfield, the Pentecostal Church, Revival Church of Enfield, open itself, its place, its heart, to kind of get this message across about health and how we can all work together. And this 3T's model of engagement of trusted leaders, trusted voices in trusted places is the way that we're currently working in London in terms of vaccination and screening inequalities, disparities. But moreover, it's about the same thing, building trust and confidence with our communities. And it was the same kind of way of working that fostered us to look at developing a key network of connections across London concerned about Bangladeshi health inequalities, including myself, Dr. Sharmin Shah Jahan, who's our co-chair, Deputy Director for Voice for Change England, Kausar Zaman, Community Engagement for BARTS, long-serving in this community, and Bashiruddin, who's the CEO of Bangla Housing, and Shuman Banerjee, the DPH of Tower Hamlets Public Health, and other trusted leaders. So we came together and we got funding from London Health Equity Partnership, or LEP, and we're able to form this LBHP, this London Bangladeshi Health Partnership, to begin to develop the network and actually hold this summit today. And we are a rich mix and kind of amalgam of community development professionals, NHS, local government, and above all, we're really interested in understanding the principal needs of Bangladeshi health, principal health needs of the Bangladeshi community, and we're wanting to develop a strategic work plan. And today is an opportunity to start that process collectively. So we are here to respond to the health priorities for the Bangladeshi communities. We're working with Tower Hamlets, with other public health teams. We're working with, moreover, and want to work with our faith and community leaders across London, and particularly Tower Hamlets and Newham, so that we can bring people together for the first time ever in this work of bringing health and community work in partnership. So on your tables, you will see some data packs. And these data packs have been very meticulously prepared by our NHSE digital team. And I'd like to thank Faisal Mangara and colleagues for that. What we have for the first time is a demographic profile community, Bangladeshi community in London. And it shows quite clearly there that, yeah, it is the most poorest ethnic group. You are twice likely to get diabetes. And there's so many things there about vaccinations and breast cancer screening uptake. But it's not all a loss. It's for us to now build that consciousness, build that understanding, and for us to collectively work together so we can actually start serving this underserved community and all our underserved communities in this wonderful, vibrant city that we call London. I'd like to thank Voice for Change England, the NHSE PMO team, Tower Hamlets Council, Bangla Housing Association, BARTS, NHS Trust, Diabetes UK, and North East and North Central Cancer Alliances. Our speakers, our facilitators, our morning chairs, our afternoon chairs, and all our scribes. And above all, thank you for coming today to make it not just a meeting for the sake of a meeting, but a meeting that will be a call to action. Because today, London is calling for the Bangladeshis across this capital. Thank you again.
I'd like to say that I grew up in Tower Hamlets, studied school, college, university in Tower Hamlets. So this is my home. And before starting my talk, or I'll start my talk with this, a successful initiative of advancing health equity in Bangladeshi community in Tower Hamlets. In 1998, I joined a research project. It was in partnership with Tower Hamlets Health Strategy Group, then now known as Social Action for Health, with Dental Public Health at Queen Mary's University, and local authority and local health authority then. I was involved in collecting data for tobacco chewing in Bangladeshi women, so it was a prevalence study. We found that 1 in 2 Bangladeshi women chewed tobacco in pan, Around the same proportion of Bangladeshi men smoke cigarettes. So we presented our findings to various stakeholders, and the health authority then got Health Action Zone funding, and we got the funding to develop a bespoke service for tobacco cessation in Tar Hamlets, addressing the need and addressing the gap in service. So we developed Bangladeshi Stop Tobacco Project, and I'm telling you why it is successful, because we recruited bilingual local staff, trained them to become smoking cessation advisors. At the same time, we trained NHS as well as Asian Quitline telephone helpline staff, counsellors. Around the same time, Department of Health got attention of our project, and they funded a pan-London Ramadan campaign. And I recruited, again, across the 32 boroughs, smoking cessation advisors, trained them, bilingual staff, trained them to become smoking cessation advisors, and sent them to London mosques with 100,000 Ramadan timetable, with key messages, as well as the telephone helpline number to give up smoking and chewing tobacco. And then I changed my role and joined Tar Hamlets Public Health, then in the Primary Care Trust. And I became the lead for smoking cessation in Tar Hamlets. And I'm very happy to say that that service is now part of the mainstream service and at Queen Mary University. And this is just an example how relevant data is important to give evidence of need, identifying a gap in service, and then having the funding to create this bespoke service with targeted, tailored service to cater for the need of a local community. And those of you who don't know what tobacco chewing in Panis, this is just to illustrate, is betel leaf taken with areca nut and lime paste, and often taken with either processed flavored tobacco or raw tobacco leaf. And we know that tobacco cessation is important, and it's a marker of health inequality. Around the same time, while I was working in the tobacco prevalence study, I started my PhD, and I am thankful to Barts Health because they funded this research project. And I studied the factors influencing access to health services in the Bangladeshi community, the help-seeking behavior after heart attack, and varying perceptions of health and illnesses between health service users and health service providers. I studied various models of access, social and behavioral. For this study, what was important for access to health services were acceptability factors and accommodation factors. Also, patients' predisposing factors, enabling factors, and their needs. These influence their personal health practices, their help-seeking behavior, and the patterns of use of different health services. For example, the idea of prevention, having immunization, vaccination is important, but also their use from access to health services from having heart attack symptoms to actually accessing medical service. It was delayed. So this is a very simplified version of the conceptual model of help-seeking behavior and the factors influencing access to health services for this cohort of patients. You can see there are barriers from both sides. Organizational barriers, as well as differences in health beliefs. I mentioned the idea of prevention and perceptions of illnesses and help-seeking. So this is a problem to address. How do you address that? Well, the example I started off with as a success story by working with multisectoral partners, increasing recruitment and retention of bilingual staff, and by that I also mean career progression of staff to keep in place. Having relevant and meaningful data, not just quantitative data, but qualitative data as well. And having awareness-raising campaigns funding bilingual and culturally appropriate interventions. Over 2 decades ago, Dahlgren and Whitehead proposed the social determinants of health model. One key element is missing in this, and that is racism. By addressing racism, we'll address the historical barriers that leads to health inequalities. And we know that equality and equity are not the same. Equity is when everyone gets the same outcomes with resources distributed according to their need, and equal outcomes through the removal of structural barriers. And the organization I work for, Voice for Change England, aims to advance race equity and strengthen BME voices by addressing the structural barriers that can disadvantage BME communities. And there are different types of racism. We need to work collectively to address this. COVID-19 pandemic have shown us that the pre-existing health inequalities in the Bangladeshi community impacted them disproportionately. And we need to take this seriously because that magnified the needs of the Bangladeshi community, and we need to reach and address those needs with equity and health perspective. And by addressing the root causes of health disparities, we can improve health outcomes. And by that, we can reduce overall healthcare needs. It has been proposed that racism is the root cause of ethnic health inequalities, both directly and indirectly. And NHS and other government agencies have got a strategic framework to tackle ethnic health inequalities through an anti-racist approach. And you can see, for example, I mentioned data, work in partnerships, workforce commitment to target health equity have also been part of my conceptual model and recommendations. And that was 20 years ago. I did my PhD. So this, we are all together, and I'm delighted to see everyone. This summit is a multi-sectoral partnership in action, advancing health equity. And from Voice for Change England, I'm happy to be part of an organization that is addressing the wider determinants of health and reducing health inequality. We're a national membership organization advocating for the BME VCSE sector, and our vision is to build a stronger, more inclusive civil society to meet the needs of the BME communities. We give out grants, we offer organizational infrastructure support, and we campaign on topical issues, policy, and promote democratic rights and participation in wider civic life. We collaborate in groundbreaking racial equality research and exploring the barriers to BME VCSE participation in the climate justice agenda. Our membership is open to everyone and it's free. So if you are interested, you can scan that QR code and it will take you to our membership page. We have full membership for BME organizations and individuals, and associate membership for non-BME organizations and individuals. And I'm glad that I am part of this London Health Bangladeshi team, that our partnership is really good. We have so many stakeholders and multi-sectors working together, but we couldn't have done this today without everyone's support. And I'd like to introduce our Vice Chair, Pastor Zaman from Bath's Health, to say a few words. He has been with us throughout the journey from the launch of this partnership last year and today. And I hope you will be with us and supporting us, and Bath's Health will support us in future as well.
So I'd like to say thank you to all of you on behalf of the Bangladeshi community, that you all came here for call to action of the health inequalities Bangladeshi's community historically facing for a very long time. It's now time to do something about it. From my organization, Bath's Health, you see, we cover a large part of East London, almost whole East London. And about 80% Bangladeshi people lives in this part of London. Bath's Health commitment is so high towards this cause, towards improving the health inequalities faced by the Bangladeshi communities. You can see the chair, Tahsin Chaudhry, the consultant diabetologist of Bars Health, is here chairing the meeting. You can see Ajit Abraham, our inclusion director, is a consultant surgeon. He is here as well. Beth Brown will be here, who is the engagement lead and people participation lead for our trust. She'll be here soon as well. And you all came from NHS England, NHS London, Greater London Authority, local councils, local NHS. We are so grateful. We need to do something about it. Your attendance shows the commitment for the health inequalities communities facing, and particularly Bangladeshi communities facing. It's time to do something. You are trusted people in trusted places. Our communities, our faith communities, our BCS sectors, we all need to work together to do something about it. No more speeches, no more datas. We have evidence, we have datas, we have research, we have everything. I remember Reverend James in the NHS London event, who stood up and said, no more studies. We need to do something about it. It's time to do something about it. Thank you so much.
So as you've heard, I'm Kevin Fenton. I'm the Public Health Director of the city. Some of you recognize me from TV, as somebody said to me this morning. Others of you recognize me because I've been around through the COVID-19 pandemic, working with the Mayor of London and the GLA. I work with the Department of Health. I work with the NHS. And my role in London is to bring together the public health family so that we are ensuring that London's approach to improving health, to tackling inequalities, to have the difficult conversations that we need to have as a city to move forward, that we are facilitating those conversations. Now, one of the difficult conversations is our work and our leadership on tackling and naming racism, and racism as a public health issue. And I've been asked this morning to reflect on why this is the case, what can we do about it, and how do we need to change our collective and individual behaviors if, having now understood the importance of racism and health, we are going to be part of changing that narrative and changing that reality. So in the time that I have available this morning, I'm going to be doing a few things. First, ensuring that we have a common definition of what racism is and that we're able to understand its impact on health. I'll take you back to the COVID-19 pandemic just to remind you on how structural racism and discrimination worsened COVID outcomes for so many people by virtue of their access, experience, and outcomes of healthcare services. And then I'm going to focus on moving forward and why anti-racism and an anti-racism approach is so critical to the work that you're doing here in East London. But before I jump in, I want to acknowledge that what you're creating today in the London Bangladeshi Health Inequalities Summit and the call to action is part of the solution that needs to take place across communities, across the city, as we begin to tackle inequalities. We now know better, and we must do better. We now know better, and we must do better. And doing better is doing this. Coming together, having difficult conversations, being honest and open and authentic, being vulnerable, in order to push through to a better and different outcome. Now, one of the roles I have is as the president of the Faculty of Public Health, and we have been absolutely clear as a leading voice for public health in the United Kingdom and globally that racism is a public health issue. And we define racism in a number of ways, but this is perhaps my favorite and most helpful definition of racism. It's by a Professor Kamara Jones. She works in the United States. She's been a dear colleague of mine for many decades. Now, Kamara describes racism as follows, that racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks. And in the case of racism, it's how we look depending on the color of our skin, right? That is what is assigning value to us in society, literally the color of our skin. Now, the problem of assigning value based on the way one looks is that that unfairly disadvantages some individuals and communities, and we know that it unfairly advantages other communities and individuals. But put together, what racism does is that it saps the strength of the entire society through the waste of human resources. I'm going to say that last phrase again because it is so important. Racism doesn't just affect me or you or us as individuals. It saps the strength of the entire society through the waste of human resources. And let's talk about race this morning because we're going to get honest, right? My job is to wake you up this morning and get you present. We waste human resources when that young black boy does not achieve what he should achieve in school because of low expectations. We waste human resources when that young Bangladeshi girl is denied opportunities to be her full and present self and to maximize her life chances through the jobs that she could get, the education that she could get, by being told you're not ready to move up to that director role or you're not ready as yet because of who you are. We are wasting too many human resources in the NHS, in our educational systems, in all of our structures within society because of racism. And in an era where we're now speaking about productivity and economic growth, then we must tackle these issues that result in bullying, harassment, people feeling disengaged, people feeling sick, they're not coming into work because of the impacts of structural racism on their lives. Does this definition resonate with you? All right. As you can tell, I love an interactive discussion, right? So either physically nod your head, raise your hand, say amen, whatever you want. Does this resonate with you? I'd like that because this is the crux of the lecture today. And if you leave with nothing, I ask you to leave with this definition from Kamara Jones, because it is why we're here today. It's why the community action is so important in helping us to name racism, to understand its impact, not only on individuals, but on society. And it also tells us what we need to do to go beyond it. Now, there are different ways in which we can view racism as a public health issue. I often speak about it as a wicked issue. It's wicked because it's complex. Nobody wants to talk about it. It often goes from generation to generation, and the reasons why we are experiencing it are many. There's not one single reason why, and no, there's not one single solution for it. And in fact, if you are in the business of tackling structural discrimination, racism, it requires many actions by many players operating at the same time with a vision for change. It is detrimental to health because what it does is that it prevents you from trusting services, from accessing services, from getting the quality of services that you deserve. And even when you get your quality services, your experiences of recuperation and recovery might not be optimal because you're treated differently. And the health consequences of racism intersect with other disadvantages. So, for example, here in East London, we know, as Riyadh said this morning, that there's an intersection between race and poverty. There's an intersection between race, gender, and poverty. There's an intersection between race, gender, poverty, and sexual orientation. And where all of these things meet, you begin to see more and more disadvantage and worse health outcomes. And so we need to understand not only the role that racism plays, but how it intersects with other forms of discrimination that results in many of our communities being so disadvantaged when it comes to their health. Now, the race riots which occurred only a month ago, I don't know about you, but they're still real to me. They're still painful to me. And it says that the narratives that we're no longer a racialist society or racism doesn't operate here, doesn't fit with our lived realities and experiences. But it doesn't mean that we should be discouraged, but it just means that we can recognize our realities, the realities faced by our communities, and to continue our commitment to push forward. We know that racism manifests itself not only in the health and care system, but in the educational sector, the housing sector, in policing in London, in court sentencing. It is manifest in many different ways. And one of the things we've seen over the past couple of decades is the more an organization says we're not racist, it's the more likely you are to find structural and institutional racism in play. And there's a key part of what we do in tackling racism, in encouraging organizations and leaders to be honest. You know, we wouldn't put up if women were systematically disadvantaged in the workplace. And in fact, much of the progress we've made over many decades has been getting equal opportunities and equity for women. We know the LGBT progress over the past 40 years, especially during the period of the HIV/AIDS pandemic, has been about recognizing equity for LGBT populations. Similarly, we now need to be pushing for that equity for all populations, irrespective of race, because it is the right thing to do. Now, racism impacts health in many, many ways, and there have been a number of studies which have been done. And in fact, since the pandemic, because we saw so quickly the inequalities manifested in the COVID-19 pandemic, that it has spurred a new generation of studies on racism and health, because people were amazed and dismayed at how quickly, how forcefully those inequalities in COVID-19 manifested themselves. But make no illusion to this, inequalities way existed COVID-19. The fact that Black women are 4 times more likely to die in childbirth than their white counterparts existed before 2020. The fact that 40% of South Asians are likely to have a 40% higher likelihood of dying from heart disease existed before COVID-19. The fact that Black men are 3 times more likely to die from prostate cancer existed before COVID-19. And in fact, since COVID-19, do you think these inequalities have gotten better or worse? Thank you. Listen, I'm going to have to go to Lambeth and see if I can get better response from Lambeth, right? I'm only kidding. You guys are great. But this is important for us to really understand that these inequalities are persistent and they're pervasive and will require radical disruption for us to break through this. We're seeing some of that now in how we think about Black maternal care. We need to think about it as we think about Black men and prostate cancer, and we certainly are doing work now on heart health and the Bangladeshi and the Pakistani community, because this is unacceptable and it's happening on our watch. Let's look at how racism manifests itself in the health and care system. There are 5 main ways in which we see structural racism in operation. First, structural racism negatively impacts your ability to access healthcare services. Again, if you remember from COVID-19, do you remember when we were trying to get people to come into the hospital to get tested for COVID? I remember because I interviewed 4,000 people in those first few months of the pandemic. And I heard stories of people saying, "Doc, I don't trust the hospital because they've never treated me and my family well. And I'm afraid if I go in, I'm going to die from COVID. And I'd rather be here at home where I know I'm around and being with my loving family than to go into hospital." So that was a really good example, and it's quoted in the report, of trust and the pre-existing experiences that our communities have with the health and care system. Now, I'm not saying this is universal. There are many people who have great relationships with the hospital, fantastic relationships with their GP. I'm using this as examples of how access can be affected. We know that racism can cause bias in clinical decision-making. Assumptions that are made, for example, about pain thresholds for Black and brown women compared to white women. The assumptions which are made about whether somebody coming in for pain medication is actually potentially a drug user, so we're going to give them aspirin rather than giving them the really powerful sort of analgesics that they need. Or the fact that assumptions are made that, okay, this person isn't really health literate, so we're not going to really listen to what they're saying or to other their symptoms and to downplay their symptoms, which results in late presentation and late diagnosis of disease. Racism also affects patient outcomes. You've seen some of the inequalities which I've discussed. And fourthly, workforce disparities as well. And COVID taught us that if we're not treating our own staff well, if there are high levels of bullying and harassment and discrimination in your workforce of your Black and brown staff, those staff come from your local community. Those staff are telling stories to their local communities about their experiences in the health and care sector. And that results in some of the discrepancies that you see. And then the final area is lack of diversity in clinical trials. Again, you'll remember this from the COVID-19 pandemic. And how many of us did town hall events when patients said, members of the public said, "Doc, how many Black and brown people were in that COVID vaccine study of 28,000 people?" And when we looked at the data and we said, oh, there were 220. They said, "Doc, why should I trust the vaccine when you didn't even bother to recruit Black and brown people?" Right? These things matter. And when you have structural racism playing across the health and care system in this way, you will have these impacts. Now, colleagues, I think my time is coming up shortly, so I'm going to be coming to an end. I'm going to talk very briefly about COVID-19. You have seen these data, and the slides will be available for you to look at. But the impact on COVID-19, as I mentioned, happened very fast. We saw disproportionate burden on Asian, Black, mixed populations occurring within the first few months of the pandemic. We saw the impact of living in overcrowded or multi-generational households, people whose jobs involved engaging with members of the public or being healthcare workers. If you lived in more deprived parts of the country, you're far more likely to be diagnosed with COVID and to die from COVID. And of course, we saw the impact of structural discrimination and racism and trust and confidence as drivers of structural racism. We now know that racism is related to poor health outcomes in different ways. And this pathway here, which I hope you can see from the back, links what I said earlier about the intersection between racism, discrimination, and poverty. Because if you have poor life chances because of your experience of structure, you're more likely to be socially and economically disadvantaged. And if you are both tackling poverty and racism, then you're less likely to have good access to services, good diagnosis of services, poor quality of care, and therefore poorer outcomes. I'm going to then finish by showing this as my final slide, in that our strategies for tackling both racism and structural racism and health began and were shown in our response to the COVID-19 pandemic. So I ask everyone individually to do three things when it comes to tackling structural racism. First is to say it. Name racism. Name structural discrimination, because it is in the naming of it that you're able to shine a light on it. And it is important that we, as we work authentically and honestly, are able to name these difficult and challenging issues in order to move forward. Second, I ask everyone to see it. See how structural racism and discrimination is operating in your team, in your organization, in wherever you're working. And understand that if you can see and name it, then you begin the process of being able to address it. And finally, the third ask that I have of each of you, to see it, to say it, to see it. And the third ask is to act on it. Work with your managers, work with your leaders, work with your peers to say that this discrimination, this disadvantage is operating here, and here's what we can do about it. Now, COVID taught us that there are a few things that we need to tackle inequalities. And this will be my final slide, because COVID taught us that in order to have success, we need to have well-resourced and equity-focused public health, healthcare, and pandemic preparedness systems. We need that investment so that when we have major threats and challenges, we have the robust infrastructure ready to respond in ways that we didn't perhaps with COVID. It taught us about the importance of strong partnerships. We could not have got through the pandemic without the strong partnership between statutory agencies, between government, regional and local partners, but most importantly, the partnership with yourselves in the community. It taught us about the importance of investing in high quality research, research that gave us data, research that was centered in communities, research that responded to the questions that you as communities were asking. It also taught us the importance of community-centered approaches and really ensuring that we're continuing to support outreach, engagement, and mobilization, exactly what you're doing today. So colleagues, in ending, 5 asks of you as a system when it comes to ensuring that you integrate structural racism as part of your work on tackling inequalities, and 3 asks of each of you on your individual actions for tackling structural racism. And repeat after me, my last bit of interaction this morning. I've asked you to see it, say it, and act on it. Thank you very much.
So 34% of the population in Tower Hamlets is Bangladeshi, so it's really important. So all our approaches have to be centered around the Bangladeshi community and what works for that community. So that's about 84,000 people. This is a slide, it looks a little bit complicated, but it really, I want to spend a little bit of time on it because it really explains why the health and well-being of the Bangladeshi community is such a burning platform in this borough. So Tower Hamlets has one of the fastest growing populations. So the population in Tower Hamlets is about 330,000. Over the last 10 years, it's grown by about 50,000. And so when people look at Tower Hamlets and how things have changed, people say that the levels of deprivation in Tower Hamlets are reducing. In fact, when you look at it in more depth, what you find is actually the people who are moving into Tower Hamlets tend to be more affluent. But when you really look into it, in our joint strategic needs assessment that we did this year, we used a new indicator, which is called the ethnicity group deprivation indicator, which looks at a set of factors such as housing, overcrowding, that are linked to deprivation. And what it shows is really quite stark, because although if you look at Tower Hamlets, generally most of the areas are sort of in the 20th to 50th percent of deprivation. So more deprived than the country as a whole, but sort of not the most deprived in general. But if you break that down by ethnicity, what you find is that the Bangladeshi groups within the borough are almost entirely within the bottom 10% in relation to deprivation. So they are the 10% most deprived nationally. And that is a really significant, important factor, because it means that you really have to go into communities to understand the impacts of deprivation on health in the Bangladeshi community. So we really need to be very localized in our approach. And then this is reflected in a number of the statistics that we have from the census and other sources. So around over 30% of Bangladeshi populations in this borough describe their health as not good, which is the highest in the borough. This is data from primary care, and it really brings home the inequalities here. And I had to double check when Liam in my team presented this to me, because what it shows is that by the age of 70, the chances of someone, if someone is Bangladeshi, their chances of diagnosis of diabetes is 1 in 2, compared to 1 in 4 in the rest of the population. So that highlights the extent of the inequality that we are facing in this borough. And that translates into other factors that are related to heart disease. So high blood pressure, it's a similar story. And heart disease, by the age of 55, it's around 3 times the rest of the population. Also, including here kidney disease, which is not often talked about, but is really linked to diabetes and vascular disease. And that shows the extent of kidney disease in the Bangladeshi populations. Again, some of the sort of key screening programs in the borough, they consistently show lower uptake in the Bangladeshi community. This is one example. This is breast cancer screening, and the Bangladeshi women have the lowest uptake of breast cancer screening in the borough. What we do see is that the mortality from breast cancer in Tower Hamlets is higher than elsewhere, and that doesn't necessarily mean we have higher levels of people getting breast cancer. What it suggests is that we have later diagnosis, which impacts on your chances of survival. So that's one example. I haven't put the graph up here, but the other area that we really struggle with and that we'll be talking about later today relates to immunization. So at the start of the pandemic, the uptake of the COVID vaccination in the Bangladeshi community was actually really high. But over the last year or so, it has absolutely plummeted, and the Bangladeshi community have the lowest uptake of COVID booster in the borough. And we've asked about that, and it's not just a story about vaccine hesitancy. A lot of it is about the system. So we've done focus groups, and people are saying sort of simple things like, actually it'd be really good if we got a letter from our GP telling us why we need this vaccine. We've had this vaccine 4 times. Why are you asking us to have it again? So there's some simple things within the system that, well, they seem simple, but Moira there will tell us that actually that these things are not as straightforward to fix as we would want them to be. But that is, I think, one of the reasons why we're here and where we can take action in terms of what are the simple things we can do to fix the system, and why are we not able to do that. So immunization, another area of real concern in order to really protect our most vulnerable populations in the borough. Gestational diabetes is another area. So you can see here again that Tower Hamlets has the highest levels of gestational diabetes in northeast London. The other thing that I haven't put the data here is that it's really striking that in Tower Hamlets, across northeast London, we have the highest levels of late take-up of antenatal care. So we have high levels of gestational diabetes, and we have women seeking antenatal care later, and that's a real concern. In fact, it was at the Health and Wellbeing Board yesterday. This is a real issue, but it is something that, again, that if we work together, we can address through engaging with communities. So just following on from what Kevin was saying, I think 3 reflections from the pandemic, and actually what Taz was saying, that this is an emergency. So if you think about diabetes in the same way as we thought about COVID and the urgency that we applied for it, this is a non-communicable disease pandemic in our community that is happening today. And we know, for instance, people will be going through BARTs today, and they will be getting their treatment, but some of them may have undiagnosed diabetes and they may come out of BARTs and that may not have been picked up. Or, there's a lot of settings. People going to the mosque on a Friday may have all sorts of conditions, and that's a real good opportunity for us to diagnose undiagnosed conditions. Whenever we do a clinic in the mosque, we find, if you take 100 men, you'll find about 25 who have undiagnosed high blood pressure. You'll find about 25 who have a diagnosis of high blood pressure, but their blood pressure is uncontrolled. So there's a lot that we can do, as Riyad was saying, about working in community settings with communities to improve people's health. The second thing, and I think that this was really frustrating during the pandemic, was about ethnicity monitoring. So if you don't measure something, this is feedback we got both also from people with disabilities, that if you don't measure something, it sends out a strong signal that you're not really valuing it. But it also means that we don't know what the relative impacts of our services are. So there is a real challenge about ethnicity monitoring and making sure that we are using that data to improve services. And then the third thing, which really came out during the pandemic, was really the importance of what we're all talking about today, which is the importance of connection with communities to make a difference, and understanding what will land with communities and what is going to work. Just so finally, I just wanted to talk a little bit about the principles that we apply in thinking about how we respond to these issues. So these are the principles that we developed with the community about how we should think about our health and care system. So we got 6 principles. The first one was actually resources need to go to those who need it most, which seems really obvious, but actually you can only do that if you really understand your communities and where the needs are. The other one was around feeling connected and how important that is to well-being. Social isolation, loneliness is a major issue in this borough. We know the impact of how, if you do address that social connection, actually if you bring people together with long-term conditions, that is actually a really powerful asset that can help improve health and well-being. The third thing that really came out during COVID was the importance of being treated with respect. It goes back to what Kevin was talking about, the impact of racism actually on the effectiveness of health and care services. So racism was something that really, the experience of racism in using health and care services was something that came out very strongly during COVID, but also before COVID. The fourth, I think, is really important, which is that the information that we are trying to disseminate to communities needs to be co-produced with communities. So there are so many different ways of communicating, and some will work for some populations and some won't work for others. And I think this is a really powerful message, which is about how you co-produce messages and communications with communities, because it can make a really big difference. The fifth one is all about co-production and actually how people should feel they have equal power in shaping and designing their services. So if we think about diabetes today, actually, how do we co-design those authentically with the Bangladeshi community? And then the last one is really important too, which is about actually how do we make the best use of the assets that we have. And we're very lucky in Tower Hamlets. We have amazing voluntary sectors, and actually through COVID, the faith sector was really valuable in shaping our response. So how do we use those assets more effectively? And again, that is another thing that's going to be really central to our discussions today. So I'm going to stop there. Thanks very much.
Brilliant. So I'm so delighted to be here because I used to be a house officer over in that building. I won't say how long ago, but it's really lovely to be back here. I trained at Barts in the Royal London as a doctor many years ago. So I'm very well versed in the needs of the Bangladeshi community. And I now work in West London, and my research and clinical practice has really been focused on this idea of early onset type 2 diabetes. Now, we've known for a while that type 2 diabetes can present throughout life, and obviously we're very familiar with it occurring in middle to later ages. But more recently, probably in the last 15 years, I would say, we recognize that type 2 diabetes can present in early adulthood, defined as before the age of 40. And also, sadly, in children, and that always makes the headlines every year. Some of you may have seen it, that there are more and more youth with type 2 diabetes. And the reason that this is worrying, wherever you put your cutoff for age, is that when you're diagnosed with type 2 diabetes earlier on in life, you have much worse outcomes compared to someone that's diagnosed later on in life. So this is a graph which really explains the problem, and it's a graph that came out last year in a publication where they looked at about 100 million people from lots of different high-income countries, and they plotted the life expectancy depending on the age at which you were diagnosed. And this blue line here are people that are diagnosed with type 2 diabetes at the age of 30. And what you can see there is that if you're diagnosed with type 2 diabetes at 30, you lose 16 years of your life expectancy. So you die 16 years earlier than someone diagnosed later on in life. And this is the graph for if you're diagnosed at 40, 50, 60, and 70. And this is in women, and it's a very similar picture in men. And actually, if you're diagnosed at 20, you lose about 20 years of your life expectancy. So this is really, really worrying. Now, we've heard about the complications in the Bangladeshi community in the previous talk, but if you take someone that's diagnosed with diabetes type 2 early in life, they are more likely to develop diabetic kidney disease. Women have poor pregnancy outcomes, higher rates of neonatal death, sadly. There is a greater risk of diabetes distress, associated mental health conditions, and also multiple long-term conditions. Some of my patients are in their 20s and they already have 3 chronic conditions. So we think about multimorbidity and frailty as happening in the older ages, but actually we're now seeing these conditions develop in people of working age with young families, planning pregnancies, arguably the most productive members of our community. What do they die from? Mostly cardiovascular diseases and end-stage renal disease. And so, sorry to paint a gloomy picture, but this is really, really a worrying epidemiological transition. So, I lead the Young Type 2 Diabetes audit in the NHS England Diabetes Programme, and we decided to look at the numbers of what was going on. So what you can see in this table is that in the last 5 or 6 years, the numbers of people with type 2 diabetes have gone up in total, but they've disproportionately gone up in people under the age of 40. So we've seen about an 18 to 20% increase in the cross-sectional prevalence of type 2 diabetes in people under 40. And actually in older age groups, it seems to be plateauing. But the highest rising group are these younger people. So why am I here today? Well, it's no surprise really that the people at risk of early onset type 2 diabetes are the people that we are all serving. And when you look at the studies, what they show is that younger people with type 2 have a higher dose, as I call it, of the traditional typical risk factors for type 2 diabetes. So in younger individuals, we see more women affected up until the age of about 25. There's a strong association with living with obesity and overweight, a strong association with socioeconomic deprivation, and a disproportionate representation of minority ethnic groups. And we've looked at this in the audit, and if you try to predict what the prevalence should be for people in Asian or Black ancestry groups in the UK, it far exceeds what you would expect, taking into account the higher risk in those groups. Now, this is a graph that I put together over the weekend, and it shows the prevalence of early onset type 2 diabetes in England. Now, in total, we've got 140,000 people under 40 with type 2. Maybe it doesn't seem like a big number, but it's growing. And guess which region of London is highlighted there with the yellow arrow? Any guesses? Northeast London. So you do have the dubious honour of having the highest cross-sectional prevalence of early onset type 2. And this one here, second, that's my ICB, Northwest London. Okay, so we're just behind you by about 200 people. It's not a competition. And if I plot in your ICB, the Northeast London, by PCN, what I want to draw your attention to is the huge variation. Okay, so we've got some of your PCNs that have nearly 500 people living with type 2 under 40, and we've got others with about 50, okay? And this is very important. I'm not going to dwell on it, but when we talk about the skills and workforce needed to support these individuals, it's not the case that those individuals are going to be deployed everywhere, okay? So we need to think about how we deploy our resources. Now, I'm clinical advisor to the T2 Day program, which stands for type 2 diabetes in the young. And in my last couple of slides, I just want to explain something we're doing with some funding from NHS England. We decided we needed to try and improve outcomes for these individuals. And we are focusing on 5 domains of care, which are listed here. And essentially, because, you know, one of the previous talks mentioned that Asian or minority ethnic groups don't appear in the evidence base. If you want to know how many Asian young people with type 2 or black young people with type 2 appear in the drug studies, it's probably, I can probably count them on my hands, maybe a few hundred. So it's very difficult to know what to do with this group. There's an absence of evidence, but what we can do is make sure that we're ticking the boxes that we should be doing. And that's really what the T2 Day program is. It's been taken up by every ICB in England. It gives extra contact time to young people with type 2 diabetes so that we can optimize their care. So this is my last slide. A call to action, that's the theme of today. And we know that the British Bangladeshi population is distinct in many, many different ways, but there are a lot of similarities between what we're seeing in young type 2 in Bangladeshi, but also in other minority groups. We don't have a big Bangladeshi population in Northwest London, but we have similar rates to Northeast London. So clearly there's a lot of shared issues to deal with. Prevention is key, and the T2 Day program does not deal with prevention. T2 Day is about supporting people that are affected with type 2 now. And this is an urgent healthcare epidemic, as was mentioned earlier. For those affected, we need to address their high risk and really engage and mitigate this problem, because otherwise the next generation is going to get type 2 diabetes even earlier. And sadly, I think this problem for the, I always try to end on an optimistic thing, and I think being here is probably the optimism, but these cases are only going to go up in numbers because we're just hitting the surge in early onset type 2. So I'd like to thank the NHS England type 2 diabetes audit team and also some key members of the programme who've helped put together these data. Thank you.
Thank you very much. Messi and Ronaldo is not going to be forgotten, Shivani. We'll have to have a game sometime. Thank you so much to all of you for putting together such a wonderful meeting and for inviting me on behalf of the Genes and Health team. And I guess I'm going to look a little bit into the future and I hope bring a little bit of hope around what discoveries we can make through effective research that properly includes people from underrepresented communities, and how research can really improve the care of people at risk of and living with diabetes and other conditions. So I'm here on behalf of the Genes and Health team. We have Bodril standing over here, who's also from the team, who's happy to answer questions in any of the breaks over by our banners over there. And we have a very large team that's based now across the UK. So our primary aim is to improve the health of South Asian people. And I don't need to recapitulate any of these messages that you've heard so eloquently already as to why we're doing this. Now, Genes and Health is a very large community-based study of the health of British Bangladeshis and British Pakistanis living in the UK, aged above 16. We recruit now in East London, Bradford, Manchester, and soon West Midlands also, and we recruit anywhere and everywhere, GP surgeries, hospitals, community settings. And that recruitment is led by our phenomenal team of bilingual research assistants from British, Bangladeshi and Pakistani communities, and is really the hallmark of why we've been able to represent communities that are previously significantly underrepresented in research. So when a person joins up to our study, we ask for three things. Firstly, could you please spit in a tube, so that we can extract DNA and analyze your genes, look at the genetic code of you as an individual. We also ask for us to be able to, in a very secure way, link to your NHS health data, and that gives us vast amounts of very high quality information about that individual's health and disease over time. And finally, we ask volunteers for us to be able to contact them again in the future up to 4 times a year to invite them back to additional research studies, at which point they can say yes or no, it's up to them. So it's a simple study in its design, and really the aim of it is to work across all areas of health and disease. We have some priority areas, which are diabetes, cardiovascular disease, cancer, and mental health, that have been set by our community advisory group. But really, we're a flexible study that can meet the really broad range of health issues affecting these communities. Now, we've heard a lot actually from many of the speakers this morning about why a study like this is so important. UK Biobank is like an absolute golden study in the UK's research landscape. Researchers from all over the world say, wow, what an incredible study this is. It's driving amazing research. It is an amazing study. But when you look at the composition of the 500,000 people that are in UK Biobank, there's a problem. If you look at how many British Bangladeshi people there are in that 500,000 people study, there's 240, okay? Similar, very low numbers of other South Asian groups and other underrepresented populations. And over time, this little graph on the right is looking at the composition of genetic studies that have been performed around the world over time. Genetic studies are rapidly increasing because they're delivering potential major benefits to health. But that increase is really representing only the white Europeans of this world. And the numbers of South Asians in these studies is still appallingly low, 0.8% of participants in genetic studies around the world. So this is what Genes and Health is really trying to work hard at. And I'm pleased to say, and with support from many of you in this room, a lot of you have been great friends and supporters of Genes and Health, as well as our volunteers. We've managed to recruit over 60,000 volunteers to Genes and Health in 9 years. About 60% of those are British Bangladeshi. And this is really supported by continuous and long-term input from our community advisory group led by Councillor Ahsan Khan, who's from Waltham Forest. We are beginning to deliver some major scientific discoveries. For those of you that work in academia can see from our list of publications, we're making some really high impact scientific discoveries through the generous participation of our volunteers. And we've got partners here, there and everywhere, and particular ones to mention here are NHS partners, as well as organisations like Social Action for Health, British Islamic Medical Association and the East London Mosque. So I'm going to give you just a brief flavour of some of the work that my team is doing with Genes and Health on diabetes. And I'm really hoping this is going to give you a little bit of hope. It's long-term hope. This is all about improving care in the future, but we really hope that we're going to be contributing to those improvements. So my team studies the genetics of diabetes, and we can look in our volunteers at gene changes, very small little changes in our genes across the person's entire genome. And we can build something called a polygenic score, which is really a way of estimating the genetic risk of somebody getting type 2 diabetes. We've done this with our Genes and Health volunteers, and we've built that genetic risk estimate into something that your GP runs every day on their computer, something called a Q diabetes score, which is an estimate of whether a person is going to get diabetes or not. And what we found is that actually if you add a genetic score into that, you can begin to understand in a much better way in young people who is at greatest risk of diabetes, of type 2 diabetes. And actually the addition of the genetic score classifies about 6% of young people as being at high risk that this standard score would have otherwise missed. We can then take this genetic score, this polygenic score, and then unpick, well, what's it all about? What's it doing in somebody's body? What are the functions that are going wrong? And we know that South Asians with type 2 diabetes have a subtly different type of diabetes to a lot of other people, to a lot of other populations. And when we unpick the genetics of that diabetes, we identify that there are two particular features that put people at greater risk, and particularly at early onset type 2 diabetes. And that is the risk of being deficient or having low levels of insulin, but also of putting fat in the wrong places in the body. And many of you know that South Asians are particularly prone to having fat around the middle rather than me, who puts fat around the hips, okay? And it's the genetic risk of those phenomena that seems to particularly underlie the risk of early onset diabetes in our South Asian population. And people with the highest genetic risk in those categories are astoundingly diagnosed 8 years earlier at a lower body mass index, and they progress faster to complications of diabetes. This is a complex slide, but this is really just proving the potential benefit to some of these genetic tools, because what these genetic tools also tell us is who is more or less likely to respond to particular diabetes drug treatments. Okay, so we know that a particular genetic composition related to insulin deficiency means you're less likely to respond to an SGLT2 inhibitor, which is one of our mainstays of diabetes treatment, but you're more likely to require insulin. And this is, we hope, taking us in the future to more precise treatments for diabetes and away from the current model of care, which is a one-size-fits-all. You've got type 2 diabetes, here's the pathway. Taking us to something that is much more precise and individualized. Okay. Just two other brief snapshots of the work that we've been doing. Shivani is a real expert in understanding how to pick up what type of diabetes a person has. And this can be very, very difficult, as she's alluded to, in young people. So we've used some of these genetic scores to begin to understand actually what are the rates of misclassification of diabetes. How many people in East London who have got diabetes, who are on insulin, have been misclassified as having type 2 when actually they've got type 1 diabetes. And we estimate that's affecting about 6% of people. We've got a lot of sixes in this talk. I hope that's not bad luck. And this is going to give us a guide to really understanding that we need to do better testing at diagnosis when people are young to ensure that they're getting the right treatment. And then finally, and this is a very big emerging story, and in fact it's a particular story not just in South Asians but also in Black Africans and Caribbeans, where HbA1c, the blood test that we're using to diagnose and monitor type 2 diabetes, which is measured about 50 million times per year by the NHS, we find, and many others find, that there are genetic changes that some people carry that really affect whether this HbA1c test can accurately measure your glucose level. And this is a big emerging story. And in Genes and Health, we've identified one gene change which artificially lowers the HbA1c by 6 millimoles per litre. And we estimate that means those individuals are their type 2 diabetes is diagnosed 2.5 years later than it should be. And that's really important in terms of whether those individuals are exposed to high glucose levels and therefore have a higher rate of complications. And we've got a very large piece of work just funded that's going to be taking a lot of this work forward across ethnic groups. So that's really the snapshot, and really this is work that has been led by our huge team, and as I say, by many supporters in this room. I'd be delighted to talk more about Genes and Health to anyone in the break, and if there are groups or individuals that are not working with us currently who represent the British Bangladeshi community, we would love to partner up with you. So do come and talk to either myself or Budrul at the break. Thank you very much.
Kick off. So my name's Aoife Slattery. I'm from Diabetes UK. Tackling inequality is, of course, a huge part of our strategy. You can't have listened to this morning and not realised there's huge inequalities in diabetes. One of the ways that we look to do this is driving change through lived experience. We really recognise the importance of talking to those people most affected by inequality, and that was why I was so pleased to be partnering with Riyadh and the London Bangladeshi Health Partnership today to do more of this and this community work. A major piece of work we led on last year was the Tackling Inequality Commission, and of course there were many Bangladeshi people involved in that, talking to us about their experience of inequality in diabetes. And before I let the people who actually have the lived experience have a conversation with you this morning, I wanted to just introduce 3 themes that might help with some of the conversations you're having later around the tables that we heard a lot from people living with diabetes. The first one is inevitability. The feeling that for some people in communities, it's inevitable that you're going to get diabetes, that everyone else in your family, all of your neighbours already live with diabetes, so it's something that's just going to happen to you. And the feeling also that healthcare professionals believe that too, and perhaps you're not offered the same opportunities for prevention as other people. Assumptions. An assumption made that because you live in a community with a high prevalence of diabetes, that you already understand what you should be doing about it. And so again, that perhaps things aren't explained to you, you're not given the opportunity to learn as much about diabetes as you could, and you're not given the opportunity to have that education that other people get. And finally, the importance of representation. We've heard this morning, it really struck me what Professor Fenton said about people working in hospitals and perhaps if they're treated badly, then going out in their communities and talking about those experiences and the problems with trust that creates. But also for people going into services, if the services they're accessing don't look like the community around that place, it becomes more difficult to trust. And we heard a lot about that, about how people are given advice that doesn't fit for their particular lifestyle. They're talked to about foods they don't recognise or foods they're not able to get where they live, and how it becomes very difficult then to go back to your diabetes appointment where you're perhaps told off or made to feel you haven't followed what you were told to do when actually it wasn't something that made any sense to you. In particular, we heard from community organisations like Bangla Housing Association how important it is to talk to them because they do have the trust of the communities. They are able to help you with planning and thinking about how to provide your information, how to set up your services to make them more accessible to everyone living with diabetes. I'm not going to talk for too long this morning because I'm aware that we're short of time, but I'd like to start off to introduce Yasmin, our next speaker, who's going to talk about her lived experience of diabetes.
Good morning, everyone, and thank you to all the speakers, and a very big thank you to Dr. Shivani and Professor Sarah. So I'm Yasmin, and I wear many hats, but today I come here as a person with lived experience with type 2 diabetes. So I'm going to start off with my mom, actually, before talking about myself. So my mom is a mother of 7 children, and I'm the 3rd one down. Her mom had diabetes, and I saw that my nan had diabetes, and it never occurred to me that my mom will get it one day, and she did. Despite being such a hardworking mother, we grew up in a time where washing machines were unaffordable, and mom had to cook from scratch, whereas nowadays everything is processed and you get them in packets and life is so much more easier. Despite doing so much hard work, my mom still got diabetes. And that's why I'm so disappointed in myself. I saw my nan get diabetes, I saw my mom get diabetes, and yet I didn't think I would get it. I didn't think I would get it at all, actually. It just it just blew over my head. But anyway, 27 years ago, I had my firstborn, and I thought, okay, first child, you know, that's fine. Then I had my second, and my pregnancies were quite tough. And then I had my third, which was I had a girl. And then I had gestational diabetes. It was so tough for me, extra tough for me, because I had a phobia of needles, and I still do. And my gestational diabetes was so bad that I had to inject insulin. So it was a double trouble for me. And instead of actually working towards prevention and things like that, I actually shut down and went into postnatal depression after the birth of my daughter. And then somewhere down the line, I had my fourth child, which was a boy. And I didn't get any gestational diabetes then. And then 11 years ago, I had my last born, and I got gestational diabetes again. So with both my daughters, I got gestational diabetes. And yet still I was turning a blind eye to this condition. And so it came to a point where I had to go in for a blood test, and they said, oh, you're borderline diabetes. And I was still failing to understand that I could get type 2 diabetes. It was very hard for me when I got the news that I got type 2 diabetes. And nobody was to blame but myself. Because somewhere down the line, I forgot about number one. Because I was so busy mothering my 5 children and running that household, I thought I was superwoman. I didn't need help. I thought I could get by. I thought I would never get any of these conditions. One morning I was drinking my coffee and I was checking my phone, and I couldn't read the writing on my phone. My vision was blurry, and that's when the pin dropped. I was getting old. I'm getting old. I've got so many chronic conditions. And diabetes was just around the corner for me. I should have seen it earlier. My nan had it, my mum had it, my brother has it. Obviously, I will get it. But the difference here is I could have done something about it. Had I got the support, had I got the guidance. And that's where the barrier is. And that's where we need to start supporting people. We know these things, but sometimes we need that nudge. Sometimes we need that support. And more than anything, we need guidance. Just because my mum had it, my nan had it, my brother has it, doesn't mean I know everything. And Ify is absolutely right. Just because you're in that area doesn't mean you actually know everything about it. I didn't know much about type 2 diabetes at all. And then when I did find out, I shut the door on myself and the world. And I thought it would go away. And obviously it didn't. It just got worse because I was not getting the support that I needed. I think I'm going to stop here today because I'm going to get very emotional. But I like to say that early diagnosis, intervention is paramount. More than anything, before any of these two, prevention. Prevention, prevention, prevention. I would say prevention. And then whatever comes, But thank you so much for your time.
Morning, everyone. I'm Farzana. I want to also talk a bit about my lived experience, not too much. So I was diagnosed with gestational diabetes 18 years ago with my second child. And so it was quite devastating, as Yasmin was saying. But when I had my last child 5 years ago, I was not diagnosed with gestational diabetes. And I think the reason behind this was I sort of had more awareness and more education around diabetes. So what I did was I exercised more during pregnancy. I ate healthily and did lots of walking. And I think that's what's for me not to be diagnosed. That was the pathway for me to follow. And luckily, touch wood, I still type 2 diabetes free. So this is like a positive to what Yasmin was saying. This leads on nicely to my role as a community health facilitator for the Southwest locality. And can you hear me? Okay. And so this is a project, this is in partnership with NEL ICB and, Public Health Tower Hamlets. Some of my colleagues are here today, and we are working in a program called Communities Keeping Well, and this is, sorry, I'm just, okay. So our program is prevention of long-term conditions, particularly type 2 diabetes, heart and lung conditions. So we're focusing on those three conditions in Tower Hamlets. So throughout this program, we did some engagement with the local community, and through World Cafe events, we engaged with the local communities. We had a successful community, yeah, okay. And we had successful events in Shadwell and Harford. So public health did identify in the southwest localities, Shadwell and Harford, as being one of the most highly deprived communities in the southwest locality. We did lots of door knocking, lots of outreach work, and World Cafe events. There are some pictures here on the screen of our World Cafe events. It was a huge success with around 80 to 90 community members attending and residents attending our World Cafe event. Then moving on, just last week we had a stakeholder event, the Working Together workshop, where we had 25 stakeholders and around 45 residents attending. Through this workshop, it is to work in collaboration with our stakeholders. So we've been very fortunate in the Southwest where we've had support from our stakeholders through ranging from financial support to giving us space for our activities. So the reason for this program is for the local community to get involved in the prevention or the reducing of these long-term conditions. The next steps would be that we are inviting again the community to pitch an idea through participatory budgeting, where the local community will pitch an idea. It could be like a walking group, it could be a cooking class, or it could be just a gardening that the local community fed back through our World Cafe event. So through that, we hope to prevent, as we've been hearing this morning, these long-term conditions. I also want to sort of say that our colleagues from Public Health, Mimi, Diana, and Malaka are here today. If you have any further questions or want to know more about it, please do come and see us. Thank you.
Good morning, everybody. My name is Bashiruddin. I'm the Chief Executive of Bangla Housing Association. And you might ask, what's the Housing Association doing? You might say, what's the Housing Association doing in this health partnership? Well, what I can say is that Bangla Housing Association have been working in East London for over 32 years. And all along, we just haven't been helping people with housing, better housing. What we have also been doing is trying to help people maximizing their income. Obviously, housing is our main work, and also trying to improve their health outcome, our community's health outcome. One good example is that during COVID-19 pandemic, as you all heard, and as you all know, that Bangladeshi community had been disproportionately impacted by COVID-19. During the first and second wave, when reports started coming out that the Bangladeshi community has been impacted disproportionately, we felt at Bangla Housing Association that we need to do something for this community, for my community. So we spoken to our partners, and luckily we had a lot of support, and we are able to set up a community advice project funded by the National Lottery. And we have been quickly able to mobilize our volunteers our workers, partners, and to sort of raise an awareness within the community through translated leaflets, translated videos, and attending the TB talk shows, TV channels, and also Bangla press and media. And we were able to get through or reach out to over 40,000 people in East London. And now we are acting as the anchor for the Bangladeshi Health Partnership. And I'm proud to be a partner, not only a partner, but lead organization. We have been funded by LEF, and we are being able to employ our coordinator, Sarah. She's sitting at table 2 here at the front. Sarah, put your hand up. Okay. So being anchor organization, again, as I say, I feel proud and I feel honored to be in that sort of position. And recently, we've been working with Diabetes UK to run focus groups. And I think we are, Bangladesh is in a better place to be able to organize, arrange focus groups for the community because of our background, because of the fact that we are a trusted organization. And when we reach out to people, they respond. And therefore, we were able to organize a successful focus group on diabetes that Aoife and her team sort of supported us on that. And also, we worked with Northeast London Cancer Alliance to organize a breast cancer focus group at our office as well. One thing I must not forget, there is another very important pioneering project that we are involved in, and that is the Amar Bari Amar Jibon project. And that is a project where the Open University is leading on. It's a research project, 3-year research project. And I've got a colleague from the Open University, Caroline, has joined us. And thank you, Caroline, for coming and joining us in this very important event. Now, diabetes in the community. We have heard from our eminent speakers, panelists on diabetes. What more can I say? Diabetes, as we all know, is a serious, life-threatening disease and is a health emergency for our community. I don't need to say anymore. You all heard. Now, it's time that we need to do something about it. With good, healthy living awareness, it is preventable, and if managed well, people can live longer. They can live a long, relatively healthy life. So we have heard so much that can be done in the community and to do with raising awareness, improving understanding, and ensure access to better care for all types of diabetes. Now, Bangla is committed, as I said to you, over the last 32 years, we've been working with the community, engaging with the community, and we'll carry on doing that because our community needs support and help, particularly with health, with the health issues and diabetes, which is a major health problem within our community. So we are committed to support our community to continue to work in partnership with London Bangladesh Health Partnership, NHS, and others to do this. Thank you very much.
Everyone, and thank you very much for the opportunity to come here and talk about the pregnant ladies with diabetes. So, do I have my presentation there? So, we serve in Bart's Health, myself and Rehan, and we deal with a lot of pregnant ladies with diabetes here. So I'm just going to Say it again. All right. Okay. Can you hear me now? Yes, okay. So it's a tragedy that we actually have a perfect match for the problems in pregnancy with diabetes here. We are having women with family history of diabetes, with obesity, and the race, South Asian population, a high risk of diabetes in pregnancy and afterwards. What it brings with it, actually, if you are coming to us as a pregnant woman with uncontrolled diabetes, actually you are probably coming with some kind of abnormalities in the babies. There's a potential to have abnormalities in babies like spinal defects, like kidney problem, like heart problem. And that obviously have a discussion about continuation of pregnancy, termination of pregnancy. Doesn't only bring the physical impact on the patient, but also psychological impact on the patient and the family. If you have a long-term diabetes with vasculopathies, you produce small babies. And this is a large burden of complication and morbidities in terms of babies who are born with a small weight. So this is another big, huge health impact, not only for the woman, but also for the baby and the population as a whole. Then if you have poorly controlled diabetes, you have large babies, which comes with this more amount of water around the babies, leading to complication of pregnancy. Very importantly and interestingly, I've just heard about the high risk of diabetes in terms of living in highly deprived areas with diabetes and obesity. These are a similar risk factor for preterm babies. And we in London have got a higher preterm babies, and Northeast London has got more preterm babies. So probably it's a data we have to look at, that if you are diabetic and pregnant, you're a high risk of producing preterm babies, a very big population burden in future. Obviously, we talked about complication in pregnancy when you have diabetes, bigger babies, large amount of water, risk of cesarean section, risk of high amount of bleeding, and therefore anemia, therefore fatigue, therefore delayed recovery. You're going into the community after your cesarean section with a lot of morbidity just because you are diabetic. And then when you have all these complicated pregnancies like congenital abnormalities because you were pregnant when your diabetes was not well controlled in community, or when you have uncontrolled diabetes which leads to stillbirth. So we have got a lot of complication associated with uncontrolled diabetes, including abnormalities in the babies, stillbirth in the babies, and babies born before time. And that actually carries on in terms of a physical and emotional impact on the patients as well as the families. We talked about the window of opportunity to see these women when they are young, find out if they are diabetic, for example, gestational diabetes. I take it as a window of opportunity to prevent their conversion from gestational diabetes or diabetes in pregnancy to a long-term type 2 diabetes. So what are the barriers to improve the control of diabetes when they come to become pregnant? We have very limited resources as any other NHS trust in UK, but more often probably in part of the East London. The resources doesn't allow us to spend adequate time for the patient, to counsel them, to look after them. We are firefighting with number of the patients we are seeing. And we don't have, I think, the robust community connection so we can receive a very well-controlled diabetic patient in pregnancy. And when we send them back to the community, they have got robust system to be followed up adequately and appropriately. Then obviously we're dealing with different kind of cultures, and that variation in practices may have some different perception and practices related to a pregnant women's diet. For example, I can give you my example. I was fed like double the amount I would eat normally because I was pregnant. And I can say that many of you have been fed more because you're pregnant. And if you're belonging to a different community, the practices might be different. So we need to have a deeper understanding about these perception and practices. And obviously, women empowerment is an issue probably everywhere and most probably here as well. And I believe that this women empowerment, taking the charge of your pregnancy from the point of view of the patient, and from our point of view, I think we have failed to probably shape the expectation of that pregnant lady from this NHS care of their health problem. The expectation from a pregnant lady in this part of this London is different from probably west part of London where I was trained. And therefore, I think a lot of work needs to be done to shape their expectation to be optimal enough so they can ask for what is needed for them to have an adequate care. And there's a long list of those things. Just to summarize, that hospital journey in reality is like a fighting, and we have undiagnosed women who have existing diabetes, large number of patients, huge spectrum of complication, lot of language barrier, as we all are very aware of it, compliance issue, and as I said already, large busy clinics with short patient-doctor interaction, which doesn't allow us to provide a long-term kind of counseling to have that problem not again in future. In ideal journey, we should have a preconception counseling ideally in hospital or in community. We should have adequate and effective contraception. And we should be able to achieve a time conception so we can avoid the complications of uncontrolled diabetes leading to abnormalities in the babies and stillbirth. We must have effective GDM screening, gestational diabetes screening, optimal glycemic control, and that's how we can probably reduce the complication to the mother and the baby. And that requires a lot of resources. We can't just carry on having innovation within the given resources and pair of hands within our hospitals. I'll hope that we have this opportunity to actually do something about the resources and help us to provide the adequate kind of care to these pregnant ladies. And I leave Rehan to talk about his wisdom and vision about life post-management. Thank you very much.
I'd never worked in Whitechapel until I come in 2007, when I was very proud to be appointed a consultant here. So by a very rough estimate, if over a month, each month, I saw roughly, and I think this might be conservative, 40 women with diabetes, I reckon that by now I've done between 25 and 50,000 consultations with women with diabetes, and I'm not a diabetes doctor. So I guess I could try and tell you what I think I've learned off that. So I look after complex medical problems in pregnancy. I contribute to the Pregnancy Diabetes Service. But I see women, for example, with rare stuff from all over Northeast London and beyond. For example, some women fall pregnant who previously had a heart attack. Between 2007 and I think it was 2021, every one of those I'd met had type 2 diabetes, all of them. I see women this is super rare. Did you know women can have a kidney transplant, but nowadays they can have a baby? It's amazing. It's amazing what we can do, or rather what I watch people cleverer than me do while taking someone's blood pressure. But I think it's indicative here that a huge number of those women also had diabetes. Plus I see women in the diabetes clinic. Plus the other thing I do, in Tower Hamlets, I meet everybody who's had a stillbirth. And that clinic has no white people in it at all. And that clinic is the vast majority of who I'll see there, they have diabetes. And I think that there's something sobering about this, okay? So there are one or two things relatable here. So I'm not Bangladeshi. I'm from a place in India called Bihar. I'm a Bihari Indian Muslim. Bihar but I'm not really. I'm from Northumberland. And as Professor Chowdhury keeps reminding me, unfortunately, this means I'm expected to support Newcastle United Football Club. But what Bihar and Northumberland have in common, really, I'm very sorry to hear that. Yeah, they're poor. These are really deprived areas. The northeast, all the mines closed when I was little, and there's a lot of deprivation. And Bihar, which is also a big mining community, is the most deprived area by miles in India. When you go, it's like going to the India of 30 years ago, as Professor Abraham keeps telling me, because he's from the south. And so I hadn't worked here before, but there was something relatable, and perhaps more so because I'm 53, and at 53, my dad was diagnosed with diabetes. Or should I say my late dad? Because he's not with me now. And he did have diabetes complications, and I've got pre-diabetes. So it's not unrelatable to some of the people looking after these patients. That actually we have some idea of what might be happening. So some of what I'm doing, learning, is medical, but some of it is thinking about myself and where I sit in this community. What actually happens when you're in a clinic is you do your consultation, then you wander out to the waiting room to get someone who's the next person to come in. Now, in the antenatal clinic, the diabetes clinic, it's busy. Farah and I will tell you, it's up to 100 women in that clinic in the morning. Okay? It's a big undertaking in each of the East London hospitals, and it's getting bigger. But what strikes me going out to the waiting room is you see a lot of Bangladeshi women with their kids, and this is not a judgment, this is just what we observe, eating sweets and eating chocolate and eating crisps. Now, for those of you as parents, we've all been there. Everyone knows hospital waiting rooms, no one ever gets called on time. You've got to keep your kids happy somehow. But you can see the seeds of future diabetes being planted in the area where babies haven't even been born yet. It's extraordinary how much you can see how future health is being impacted at that point. And the thing about pregnancy diabetes, thank you for a fantastic introduction to it, it's a window into your future. As you heard from the lived experience speakers earlier, pregnancy diabetes is kind of telling you you're going to get diabetes, okay? And that's devastating. But what makes it really devastating is that in East London, the engine of East London, which keeps it going, is women. Okay? This is not just about racism. To some extent, it's about sexism and what has happened to women with regards to healthcare over centuries. So pregnancy is a massive opportunity to do a course correction in terms of health prevention and health promotion. I strongly believe that. And I strongly believe that part of why all of you came today is because you believe in the word equity. You actually think it's possible to make a difference here. So we have little things which are starting to work. Little things. No clinic needs interpreting services as much as the clinics where you look after diabetic women who are pregnant. Many of them are relatively new arrivals in the country. What a great opportunity to start up, in collaboration with the university, a health literacy project. You use the window of pregnancy to put an intervention in which could change the life of women, and could change the life of their families, and even if you don't care about equity, could change the economy of East London so that things will be better for everybody. So although I kind of am a doctor, I guess the message I want to give you is that there's more to it with pregnancy diabetes, and the impact of some of the care that we're trying to deliver has big effects on families and communities.
Beautiful, Rayhan. Thank you so much for that.
Good morning and assalamu alaikum to each and every one of you. Firstly, before I go into what I'm going to be talking about, I want to welcome each and every one of you to this fantastic building here. I think it's really iconic, and I think it's really such a place to hold such an important summit, which is talking about the health and well-being and which affects all of our residents here. So I want to welcome you to those of you who haven't been into this building. I want to welcome you on behalf of the council. It is a privilege and an honor to be here at this summit here today and to talk about some of the key challenges that we face. Health is a fundamental right and not a privilege. Yet we see and know that the access to quality healthcare and the chances to live a healthy life is often shaped by postcode, ethnicity, income, and social standing. Today, we are here to shine a light on these disparities to reaffirm our commitment to fighting for the future where health equalities is not a goal, but a reality. And as the lead member for Equalities here at Tower Hamlets, addressing this is a key priority of mine and as well as the council. The evidence is clear. Statistics show that Bangladeshis in the UK and Tower Hamlets face higher rates of chronic conditions like diabetes, cardiovascular diseases, respiratory illness. COVID-19 laid bare these inequalities even further, with the pandemic disproportionately impacting our community and leaving many to suffer the worst consequences. It is important, as part of this conversation, we are clear about the social and material factors that contribute to this health disparity. Poverty, overcrowding, unemployment, and the limited access to healthy food and spaces for our residents to exercise all contribute to the wider gap in health outcomes. This is why a holistic approach to health is important, and why any conversation about health outcome must include an assessment of the economic inequalities and the devastating consequences austerity and the cost of living has had. It is equally important that we recognize how all these issues are often compounded by the lack of access to culturally appropriate health services, language barriers, digital barriers, making sure that our mainstream services are entirely inclusive is vital if we are to mitigate the poor outcomes. Everyone here will know that if we are to address these inequalities, we must work together. This is the key. And I'm hopeful that in building up our partnership with the NHS, the council, charities, grassroots organization, we will deliver the changes that we want to see. It was really heartbreaking to hear the lived experience, and I can resonate as a resident who has lived in this borough all my life. I've got family members who suffer from diabetes, and I think it's really crucial that we tackle these inequalities. And as a council, we are doing our utmost to help work with our partners, the NHS and different grassroots organization, in order to tackle the inequalities that affect our residents. And I think, like I said, the key is working together, all partners understanding what the barriers are and facing those barriers together in order to tackle this. So once again, I finish by welcoming you all to this the town hall, and I hope everyone takes something out of this, and so that we can benefit not only the residents of Tower Hamlets but the wider community. Thank you very much, and assalamu alaikum.